for them. So without wasting any time, I would request Dr. Sivakumar to start his talk.
Thank you very much, sir. I'm audible, I suppose.
Yes, you are audible. Your slides are visible.
I personally thank Professor Kane, Dr. Milind, Dr. Snehal for inviting me for this meeting. And the session is going to be on how to interpret a hemodynamic pressure trace. Now, it's important to understand when many of the decisions in the cardiac catheterization lab are taken on the basis of hemodynamic pressure traces. And it is very important to understand how these pressure traces are generated and what are the fallacies in them, how to interpret them correctly. So let me go on to what is basically a pressure trace. Now, this particular transducer that you see, you all will be very, very familiar. If you look at these transducers, basically a long catheter through a connecting tubule of 100 centimeter will be connected into these points, and you will be seeing these small micro transducers in your cath lab. What you see here is a black color dot. So that is actually the membrane of the transducer. So whenever the blood column moves, the fluid transmits that pressure and it starts moving this diaphragm. And when this diaphragm moves, imagine that here is the diaphragm. The diaphragm will go down and up. And when it goes down and up, there are a series of resistances connected between the diaphragm and the other surface of the transducer, which has got 4 different resistors. And these are either shortened or elongated, depending on the movement of the transducer, the movement of the diaphragm. If by general rule, if the transducer is stretched, the resistance reduces. If the transducer is short, if the wire is shortened, the resistance increases. So there is going to be a variable amount of resistances created by either shortening this the wire or elongating this wire. So what happens when you pass a standard amount of current to it and you look at what is the output will vary depending on how much is the resistances. So if you have the Wheatstone bridge, this is called as the Wheatstone bridge. The Wheatstone bridge in a neutral position, the current that is passed through these resistors will come out as a standard output, and the standard output now is recorded by the machine as 0. So whenever the diaphragm moves either posteriorly or anteriorly, depending on the pressure that is generated by the fluid filled system, the diaphragm will change these resistances at G1, G2, G3, and G4, and the current output will vary with time to time. This varying current is displayed on the monitor as a pressure trace. So now comes the 3 numbers that we need to understand. What is called balancing? Whenever the fluid filled transducer is not connected to anything at all, the diaphragm is in the neutral position, and G1, G2, G3, G4 are in an unaltered state. The output that comes out should come as 0 in the transducer. So balancing means when you are switching on the transducer, if your value is coming as -2 or +2, that means the machine has to be balanced. So then the technicians just presses a button and immediately it goes into the balancing mode. And when it goes into balancing mode, the machine automatically adds some resistances to either G1, G2, G3, or G4 and makes the final output as 0. So the balancing is the process through which the machine gives an output of 0 without any connection of the transducer. What is zeroing? So very often we will say 0 the transducer, and what we say by zeroing the transducer is actually balancing the transducer. Zeroing is something different. Zeroing is moving the transducer level. So this is the 0 level of the transducer. So this 0 level of the transducer is moved to the mid-chest level. So moving it up or down to the mid-chest level is called zeroing the transducer. When we say in the cath lab to the technician, zero the transducer, what he does is balancing the transducer. And zeroing the transducer means pushing the transducer either up or down in relation to the mid-chest. And the third one is calibration. Today, in majority of the cath lab machines, it's auto-calibrated. Otherwise, in the past, they used to give a 100 millimeters mercury flick. A button is pressed and immediately it goes to 100. Then you check that whether it is at 100. Today, there is no separate calibration because all the machines are auto-calibrated. So the two things that we need to know is what is called balancing, what is called zeroing. Zeroing is moving the transducer up or down. Balancing is tell the technician, you now zero the transducer, and he presses the button 0, and immediately what the machine does is it adds a variable resistance and maintains the output at a particular amount of current that gives a 0 value on the pressure tracer. Now, in the general rule for getting the best form of pressure measurement is you should have as short a catheter as possible. The catheter should not be too large, too long. The catheter lumen should be very large. It should not be something like a 3 French or a 4 French catheter. It should be reasonably be large. The fluid should be light, which means it should purely be saline rather than some amount of blood or some amount of contrast. And it should be as much as possible a non-compliant rigid catheter. That means a braided catheter. Non-braided catheters are not good. So it should be a short braided catheter as large as possible with the saline completely transferred. Now, this is what will be here. I will show an example of a pressure transducer. This is the aortic pressure. This is the pulmonary artery pressure. If you look at the pulmonary artery pressure, the pulmonary artery pressures are showing lots of flicks with a sharp negative down, a sharp positive up. This means this particular pulmonary artery transducer is not properly damped. It is sort of underdamped. So that is the reason why there are too much of flicks. Now, automatically every machine will generate a systolic, a diastolic if you are putting in an arterial mode. So here in this particular trace, the machine will give a systolic value of somewhere around 95 and a diastolic value of somewhere around 25. But the truth is the PA diastolic is actually stopping here. And this is because of the underdamping. So one of the most important things that you should follow when you are interpreting a pressure trace is you yourself have to go and look at this trace rather than finding out what the machine records as SD and then copying it out onto your report. When you copy this patient's diastolic pressure, the sharp negative deflection that is seen by the underdamping is going to create a diastolic pressure that is far more lower than what you are supposed to get. So this is the importance. While this aortic pressure trace is properly damped and it is having a proper percussion wave, a tidal wave, and a dicrotic notch, dicrotic wave. So this is a proper ascending aortic trace, whereas the pulmonary artery trace is totally underdamped. So these are the differences that you need to understand. Now coming to interpretation of each and every pressures in different chambers. One by one, let us go. Right atrial pressure and left atrial pressure. The general waveforms that are seen in the atria is a A and a B wave. What causes the A wave is a sharp contraction of the atria during the PR interval. This atrial contraction, since the right atrium is having more pectinate muscle and the right atrial appendage is a much larger appendage compared to the left atrium, right atrium has got actually a larger A wave. While right atrium has got an enormous free wall, a large free wall, which is accommodative. Right atrium is very compliant. So the V wave, when the venous filling happens, the V wave is not very tall. I'll show an example of a right atrial pressure trace and a left atrial pressure trace and show why they are different. A wave will be followed by a second sharper wave called C wave, which will be very often not very clearly seen on a usual pressure transducer. It corresponds to closure of the tricuspid valve, and this is called as the C wave. This is followed by a large X descent. The X descent is due to beginning of the ventricular systole, which pulls the mitral and the tricuspid annulus towards the ventricle, thereby stretching the atria. So the the pull of the tricuspid and mitral valve annulus by the ventricles causes this X descent. Then subsequently, there is a slow V wave, which is a slow filling wave. This slow filling wave will reach its peak by the time the end of T wave is there. And then following that, once the diastolic opening of the tricuspid and mitral valve happens, there is a sharp Y descent. We'll show a real pressure trace where you can appreciate that this is the normal right atrial pressure trace. You can appreciate a sharp A wave. The A wave corresponds to the PR interval. A waves are always like the flicking waves. B waves are broad waves. B waves are broad because it happens to over a long period of time. It starts from the QRS complex, goes on up to the T wave. So it's a broad wave. Whereas A wave is a very short wave. It's due to atrial contraction. So when you are seeing quickly two waves, if one wave is a sharp flicking wave, it's A wave. And if it is a broad blunted wave, it's a V wave. It is applicable in clinical practice also. If you are looking at the JVP, if you are having a flicking type of impulse, that is A wave. That will be pre-systolic. It will be before the carotid. Whereas if it is a broader wave, then that is a V wave. That will be along with carotid. So that difference between A being brief in duration, B being broad in duration is an important point to understand. This A wave is caused by atrial systole, followed by the X descent, which is caused by the ventricular contraction that pulls the tricuspid annulus towards the apex, thereby stretching the atria to a larger dimension, followed by a slow filling V wave. This is due to the filling of the V wave, and then followed by the Y wave. In every right atrial pressure trace, X descent will be the prominent descent. And if you carefully look at the inspiration and expiration, during inspiration, all the pressures in the heart will go down. During expiration, all the pressures in the heart will go up. The normal inspiration, at the end of expiration, your intrathoracic pressure will be 0 millimeters of mercury, or in other words, it will be equal to the atmospheric pressure. All the pressures that we are talking about is in relation to the atmospheric pressure. So atmospheric pressure, we know that it is 760 millimeters of mercury. So when I say that my aortic blood pressure is 120 by 80, that means my systolic pressure is 760 millimeters of mercury plus 120 millimeters of mercury. And my diastolic pressure is 760 millimeters of mercury plus 80 millimeters. So basically, we are looking at it in relation to the atmospheric pressure. So at the end of expiration, when the intrathoracic pressure will be equal to the atmospheric pressure. During inspiration, the intrathoracic pressure will go to -4 to -6 centimeters of water, or in other words, -3 to -5 millimeters of mercury. That reduction will manifest on all the cardiac pressures. So you will find that the A and the V, everything will come down. So the mean pressure, the pressures will slowly come down. And during expiration, the pressures will slowly go up. Now, when you look at the mean pressure, this may not show too much of fluctuation because this mean is actually electronic mean. An electronic mean is averaging out of multiple cardiac cycles and then it records the mean. So this mean may not change during inspiration and expiration. It may remain sort of constant. But if you look at the traces will keep going down during inspiration and going up during expiration. This respiratory variation should be understood. Now coming to left atrium, the left atrium does not have a prominent A wave. Let's see why it is so. The left atrium has got, on the contrary, a prominent B wave. If you look at the left atrium is fixed anteriorly by the mitral valve, posteriorly by the vertebral body and the descending thoracic aorta, and on either side by the pulmonary veins. So there is no free space for the left atrium at all. On the contrary, right atrium has got a large right atrial free wall on the entire right side of the heart and a large right atrial appendage. So whenever there is an increased venous return from the superior and inferior vena cava into the right atrium accommodates it very, very well. So it doesn't elevate the V wave. When there is an increased venous return from the pulmonary veins into the left atrium, it is forced to increase the pressure because left atrium is not a compliant chamber at all. Left atrium does not have a large space. Left atrium is highly restricted. That is the reason why when we get into a brief period of a hypertensive crisis, suddenly when the blood pressure goes from 120 to 180 millimeters of mercury, we go into flash pulmonary edema. The reason is the left atrium is not a compliant chamber. Even a minimal increase in the fluid is going to tilt the patient down. The patient with a coronary artery disease with significant LV dysfunction, you give a fluid bolus of 100 ml, the patient will be pushed into pulmonary edema because left atrium is not a compliant atrium. On the contrary, right atrium is a very compliant atrium, will never show a prominent V wave. So that is the reason why V wave is taller in left atrium compared to A wave. And so if you look at the V and the A, the same pattern will be seen. During inspiration, the pressures will go up. During expiration, the pressures will go up. This inspiratory fall in the pressures and expiratory increase of the pressure is the rule for every cardiac pressure traces. Now, looking at if we already told that RA will have a prominent A wave because the atrial musculature is more pectinate and the right atrial appendage is large, which is again pectinate. Left atrium has got a large V wave because left atrium is non-compliant and the venous return has to increase the venous pressure. But when there is a large ASD, the large A wave of the large A wave was the right atrium and the large V wave was the left atrium will get nullified. And so you will get sort of equal A and B. But even here, during inspiration, the pressure will fall down. During expiration, the pressure will go up. So the A, V, X, and Y, I hope you have now understood. Now the question is, what happens during inspiration? As I mentioned earlier, all the intrathoracic pressure increases on expiration and reduces on inspiration. What is Kussmaul sign? Kussmaul sign is lack of inspiratory fall of right atrial pressure. Why it does not reduce when you have, let's assume, a constrictive pericarditis with a rigid pericardium around the right atrium. We take a deep inspiration, our negative intrathoracic pressure goes down. The intrathoracic pressure goes down by -5 millimeters of mercury or -6 centimeters of water, but that pressure is not transmitted into the heart because there is a rigid shield like a pericardium that is surrounding it. So typically, a constrictive pericarditis with a restrictive pericardial physiology will not have Kussmaul's, will have positive Kussmaul sign or lack of inspiratory fall. It's typical of constrictive pericarditis, but it can also be seen in a restrictive pericardial physiology with effusion also. Or sometimes rarely it can be seen in RV cardiomyopathy, RV infarction, pulmonary embolism, that means terminal right ventricular failure, severe forms of heart failure and thoracic hyposcoliosis. But remember, the typical reason for lack of inspiratory fall of pressures during inspiration is constrictive pericarditis, where the thick, rigid pericardium shields the heart and prevents the transmission of the negative intrathoracic pressure that is present within the thoracic cavity into the cardiac cavity. This is the typical example of a constrictive pericarditis. You see that this is a A wave, X descent, V wave, Y descent. Y descent is very, very prominent. The Y descent is prominent. That is basically, it's also called as a Friedreich sign. And if you look at inspiration and expiration, there is no inspiratory fall at all. You see that it's sort of static. There is no variation. If I just go back 2 slides before and show, see, this is the ASD patient. Inspiration, it just goes down. In expiration, it goes up. Every normal patient will show this. Whereas in constrictive pericarditis, it will not be there because constrictive pericarditis will shield the entire cardiac chambers so that it doesn't allow the intrathoracic pressure to be transmitted onto the intracardiac pressure. And this prominent Y descent is called Friedreich sign. We'll come to it. So now coming back to interpretation of the atrial pressures. A normal right atrial pressure should have a mean pressure of less than 8 millimeters of mercury. Anybody who is more than 8 millimeters of mercury is called congestive heart failure or elevated right atrial pressures. Now, very commonly, reasons for elevated right atrial pressure will be associated with elevated A waves. So this is the PR interval. Corresponding to the PR interval, there is a tall A wave. Here, the A waves are almost touching 18 millimeters of mercury, and the mean pressure is touching 10 millimeters of mercury. So it's an elevated RA pressure with tall A waves. Why does tall A wave happen? Tall A waves are very typical of right ventricular hypertrophy, either due to right ventricular outflow tract obstruction or right ventricular pressure being high due to pulmonary arterial hypertension. It can also be elevated in tricuspid stenosis. Now coming to how to understand this A wave. A waves are, as I told, a sharp flick with a short duration. It's important to differentiate an A wave from V wave, not only by the timing with whether it is pre-systolic or systolic. That means you put your finger on the carotid and time it, whether it is before the carotid or along with the carotid. Much more important, much more simpler way is if it is a sharp flick, it is A wave. If it is a broad wave, then that is a V wave. Broad filling wave is a V wave. Sharp flicking wave is an A wave. The reason why this is very important is whenever the tachycardia is too fast, your fingers do not understand whether it is pre-systolic or systolic very clearly. And in that case, the sharp flick of A wave and the broad filling wave, V wave, will give you easily the differentiation between what is A wave and what is V wave. So here you see that this is a normal pressure curve. There is the mean pressure is normal, but the A waves are tall flicking. On the contrary, it's rare to see a tall V wave in a right atrial pressure curve. This is a large CV wave. So the C and V are fused together with a deep wide descent. This, if it happens, that means the patient is having severe tricuspid regurgitation. Here, the mean pressure is also elevated. You can see the V waves are almost about 18 millimeters of mercury with a mean pressure of 12 millimeters of mercury. So this is a severe tricuspid regurgitation. You can appreciate the tall V with the deep wide descent. So the normal right atrial pressure, the mean pressure is up to 5, but beyond 8, then it's called definitely pathological. And a right atrial pressure of more than 8 is definitely pathological. A left atrial pressure of more than 12 is definitely pathological. Always V will be taller in a left atrium and A will be taller in a right atrium. We have to understand one thing. The A and the V waves will also depend on the rhythm of the patient. So whenever the patient is, for example, something like complete heart block, the A waves and V waves will not be proper. We may sometimes get large cannon waves. The A, it's only in a patient who is having a normal sinus rhythm with one-to-one AV nodal conduction. A and B will be representative of the intracardiac physiology. When there is a heart block or whenever there is an AV dysynchrony, the A waves and B, the waves will alter and they will become cannon waves. So coming to what are the reasons for elevated A waves, tricuspid stenosis or mitral stenosis? It can be due to severe right ventricular hypertrophy, as in pulmonary stenosis or pulmonary arterial hypertension. What I showed earlier, the cannon type of A waves are seen in heart blocks, ventricular tachycardia, ventricular pacing. Basically, this is because the A wave is happening when sometimes the tricuspid valve is closed. So a very tall abnormal wave will be seen in the right atrium and in the jugulars, that is crossed by atria contracting against a closed tricuspid valve. One of the reason is AV junctional tachycardia, which is also called as AV nodal reentrant tachycardia, AV NRT. That also produces sort of cannon-like A waves. So if the patient says that during the episodes of tachycardia, she's having a flicking type of waves in the neck during a supraventricular tachycardia, that is likely to be an AV junctional reentrant tachycardia or AV nodal, slow fast AV nodal reentrant tachycardia. Absence of A wave is seen in atrial fibrillation. V wave is very tall in tricuspid regurgitation. We also have to understand one thing. Whenever there is a reduced atrial compliance, V wave will be tall. What is this atrial compliance? For example, let us assume that you go and close atrial septal defect in a patient who is elderly. That patient will have a left ventricular restrictive physiology, and the left atrium also will be restrictive. These patients will develop a very tall V waves when the ASD is getting closed or when you are balloon testing the atrial septal defect. I'll show an example when we look at it. In constrictive pericarditis, typically the AV all will be sort of equal with prominent wide descents. It's important to understand the compliance in the left atrium. I'll briefly touch what is a compliance in the left atrium. This is a mitral stenosis. You can appreciate that this is the left atrial pressure phase and this is the left ventricular pressure phase. There's a lot of diastolic gradient. So this is the beginning of diastole to the end of diastole. So in this whole of diastole, there is a lot of diastolic gradient. There is a gap between the blue trace and the yellow trace. But if you look at the V waves, the V wave goes progressively high up to the end of the systole and then falls down during diastole. This fall is sort of slow. The slope is very slow. The slope, it takes a longer time. So this patient's V wave is stall, not due to mitral regurgitation, but it is due to reduced left atrial compliance. We need to understand this. If the VY descent is slow, takes a long time, that means the patient's left atrial compliance is very low. These patients, if they develop severe mitral regurgitation at the end of the balloon mitral valvotomy, they are not going to tolerate that mitral regurgitation because their LA pressure will enormously go up. On the contrary, if you just look at this pressure trace, you may think that it is mitral regurgitation because the V waves are taller than the A waves. But mitral regurgitation will have a different type of pressure trace. This is the mitral regurgitation. The VY descent is rather steep. It will rapidly go down. I'll just show you the previous. The VY descent will be slow. So a slow VY descent indicates poor left atrial compliance, whereas VY descent being very rapid is an indicator of mitral regurgitation. So this is mitral regurgitation. The compliance characteristic of the left atrium can be understood by looking at what is the VY descent, how the VY descent happens in a patient with mitral stenosis. Now, coming to the previously, we were seeing what are the A waves and V waves abnormalities. Now, coming to prominent X descent. X descent is very prominent in the presence of cardiac tamponade. Why? In the presence of cardiac tamponade, the entire pericardium is filled with fluid. When the ventricle contracts, the ventricle is truly reducing in its size. So that is the only time at which the atrial pressure will fall. So when the ventricle contracts within a filled pericardial cavity, the ventricular size is truly becoming, the ventricular volume is truly becoming smaller. And this results in an accommodation of the blood within the right atrium. And so there is a prominent X descent. So prominent X descent is a typical feature of cardiac tamponade. It can, of course, be seen in constrictive pericarditis also. Prominent Y descent is a typical feature of tricuspid regurgitation and constrictive pericarditis. In constrictive pericarditis, called as Friedreich sign. In tricuspid regurgitation, the prominent Y descent is a sharp feature. So I will show an example of a constrictive pericarditis, and then I will show how it corresponds to the prominent Y descent. On the contrary, blunted X descent, that means atria is not contracting at all. That is atrial fibrillation. And blunted Y descent means tricuspid stenosis. Coming to right and the left ventricle. A typical example of a right ventricle will be, a right ventricle will have a triangular sort of contour. A left ventricle will have a rectangular type of contour. I will show you a left ventricle later. So this is the right ventricle. This right ventricular pressure is almost 70 millimeters of mercury. A normal right ventricular pressure should not be more than 30 millimeters of mercury. So this is an elevated right ventricular pressure. And the right ventricular end diastolic pressure should be less than 8. And here the right ventricular end diastolic pressure is around 12 millimeters of mercury. Again, elevated right ventricular end diastolic pressure. What are the reasons for elevation of the right ventricular pressure? It can be seen in right ventricular outflow tract obstruction or pulmonary arterial hypertension. So in order to classify what is the severity of right ventricular outflow tract obstruction as well as right pulmonary arterial hypertension, we use the general rule. Up to 30 millimeters of mercury, RV pressure is normal. 30 to 50, it is a mild RVOT obstruction or mild PH. 50 to 75, it is a moderate RVOT obstruction or moderate PH. 75 and above, it is severe RVOT obstruction or severe PH. In right ventricle, end diastolic pressure has to be less than 8 millimeters of mercury. More than 8 millimeters of mercury is abnormal. So an example of a patient with the pulmonary artery stenosis, when we are doing a pullback from the pulmonary artery into the right ventricle, we are going to demonstrate the gradient. So what happens in this trace? This is the pulmonary artery trace. This is a 40 scale. So this is 20. So here the pulmonary artery pressure is very low. It's less than 10. So this is the low pulse pressure pulmonary artery trace. This indicates that the pulmonary artery is underfilled due to severe pulmonary stenosis. As you are pulling the catheter, you get into a phase where the pressure traces become very much low in its pulse pressure. That is the Venturi effect. Then once you come below the valve, immediately the pressure shoots up. What is a Venturi effect? A Venturi effect is as the blood goes from a high pressure chamber into a low pressure chamber through a narrow orifice, on the negative side of the orifice, that means the place where the pressure is low, there is something like a vacuum that is created, and this results in a marked drop in the pressure just beyond the place of the narrowing. So this is seen immediately beyond the stenotic area, but once you go for a longer distance, the pressure will recover itself. So this is called as the Venturi effect. So this is pulmonary artery to right ventricle pullback. Here you see that the right ventricle is almost 70 millimeters of mercury. Pulmonary artery is less than 10 millimeters of mercury. So the difference is 60. So that means this is almost qualifying to severe pulmonary artery stenosis. Contrary to the right ventricle pressure trace, which was rectangular, which was triangular, a left ventricular pressure trace is typically rectangular. So it has got a sharp upstroke, which is the isovolumic contraction, a sharp downstroke, which is the isovolumic relaxation, and a sort of a plateau-like state at the top. So this rectangular pressure trace is the feature of left ventricle. If you look at the left ventricle pressure versus right ventricle pressure, right ventricle pressure will have a triangular contour with a slow rise and slow fall, whereas left ventricular pressure is a rectangular contour with a steep rise and steep fall. This is how we differentiate left and the right ventricle. In the ventricle during diastole, one of the important points that we see is what is the end diastolic pressure. The end diastolic pressure corresponds to the QRS complex. What is the pressure in the ventricular trace? So this, if you look at the end diastolic pressure, it will slowly keep going up during the peak of expiration. And after expiration, as the patient inspires, the pressure keeps going down. And we need to take it at the end of expiration. Everything I'm telling that at the end of expiration, we have to measure. What is the sanctity of at the end of expiration? Already I told, when we are breathing in and out, when I am breathing in, my intrathoracic pressure is going negative. I am sucking the air from the atmosphere. So my intrathoracic pressure is going negative. Similarly, my intracardiac pressure will also go negative. Whereas during expiration, at the end of expiration, my intrathoracic pressure is at equilibrium to the atmospheric pressure. So at that time, my intrathoracic pressure is equal to the atmospheric pressure. At that time, if you record the intracardiac pressure, that is the most representative. So always we say end expiratory pressures should be recorded. So that is the importance of end expiratory pressure. Imagine that in this particular patient, there is a steep inspiratory stridor because the tongue is falling back and the patient is sedated. And so the patient is sucking in the air. So his inspiratory intrathoracic pressure will go down to minus 20 millimeters of mercury. So what will happen to this end diastolic pressure? It will also go to 0. So does that mean that the left ventricular end diastolic pressure is 0? No. It means that during the peak of inspiration, you should not take it. You should take it only at the end of expiration. So at the end of expiration, our intrathoracic pressure is at equilibrium or is equal to the atmospheric pressure. So we always take it at the end expiratory or the highest pressure. The highest pressure is taken as the end diastolic pressure. So I'll show one example of a patient who is having an atrial septal defect. The end diastolic pressure is just about 12 millimeters of mercury. You see that this is 12 millimeters of mercury, which is high normal for the 12 is the upper limit of normal. So during inspiration, it slowly comes down, and during expiration, it goes up, and it goes up to 12 millimeters of mercury. So in this patient, the ASD is actually shunting left-right. So because the ASD is shunting left-right, left ventricle is not exposed to a high volume load. So the moment you go and close that ASD, the entire pulmonary venous return now goes into the left ventricle, and the left ventricular end diastolic pressure goes higher than 20. The same pressures, which was originally 12 maximum, now it is going to 24 maximum. So this is what is called restrictive LV physiology. Or the reason why this happens is the left ventricle is now not able to tolerate this additional volume of blood that is coming from the pulmonary veins towards this left ventricle, because this left ventricle has been chronically underfilled. The same phenomenon will happen in the left atrium also. The left atrium will show a very tall V waves because the left atrium is not a compliant chamber, and so it will show a tall V wave. So this is what is the importance of left ventricular end diastolic pressure. Whenever the left ventricular end diastolic pressure is high, that patient is having a substrate for pulmonary interstitial and alveolar edema. Coming to pulmonary artery pressures and pulmonary artery wedge pressures. Let us see the pulmonary artery pressure. This is a normal pulmonary artery pressure. A pulmonary artery pressure will be less than 25 millimeters of mercury or maximum 30 millimeters of mercury. And so here in this pressure trace, there is almost about 17 millimeters of mercury systolic and about 4 millimeters mercury diastolic. So this is a normal pulmonary artery pressure trace. What is the physiological normal PA systolic pressures? 15 to 30. PA mean will be 10 to 20. Anything more than 20 millimeters PA mean is pulmonary arterial hypertension, and PA diastolic will vary between 4 to 12 millimeters of mercury. The PA diastolic pressure will be equal to the PA wedge mean. So PA diastolic is equal to PA wedge mean. So this is the pulmonary artery pressure in a patient who is having pulmonary arterial hypertension. You see that the PA pressure here is 75 millimeters of mercury with a diastolic of 20 with a mean of 45 millimeters of mercury. So this is moderate levels of pulmonary arterial hypertension. Again, if you look at it, there will be an inspiratory fall and expiratory rise, inspiratory fall. So the respiratory variation is the normal for every intracardiac pressures that you are going to see. And what the interpretation here will be moderate pulmonary arterial hypertension. What is defined as mild, moderate, severe pulmonary arterial hypertension? Any pulmonary artery pressure that is between 30 to 50 systolic is called as mild PAH. The moderate PAH is 50 to 70 PAH, and the severe PAH is more than 75 PAH. The pulmonary artery hypertension mean pressure 20 to 35, not 25, 20 to 35 is mild, 35 to 50 is moderate, and more than 50 is severe. Coming to pulmonary artery, in some patients, pulmonary artery systolic pressure will be very high, but the diastolic pressures will be very low. Or in other words, PA pressure will look like they are ventricularized. So whenever it is ventricularized, that means that pulmonary artery is having severe pulmonary artery regurgitation. So this is pulmonary artery regurgitation. So the PA diastolic is going down to very low levels. So this is a patient with pulmonary regurgitation. In patients in univentricular hearts, we have a condition called Glenn and Fontane's surgery, where superior vena cava is connected to PA or inferior vena cava is connected to PA. So in Glenn shunt, superior vena cava is connected to PA, and in Fontane, both the superior and inferior are connected to PA. In that condition, the PA will not be pulsatile. So here, this is sort of non-pulsatile. If you look at the one QRS and another QRS, there are almost 3 waves here. That means this is not a pulsatile trace. It is a sort of non-pulsatile trace. Normally, PA trace should be one systole, one diastolic pressure, whereas here it is a sort of wavy pulsation. So this is something like a non-pulsatile pressures. And here, if you look at the PA mean pressure, it's 20 millimeters of mercury. So this is a very high Glenn pressure. So while a normal pulmonary artery pressure in a Glenn and a Fontane circuit should be less than 15 millimeters of mercury, anything more than 15 millimeters is called as elevated pulmonary artery pressure. And 15 more, this is 20 millimeters. So this is elevated Glenn and or Fontane pressures. Pulmonary vein wedge can be recorded, just like how we record pulmonary artery wedge for recording LA pressure. Pulmonary vein wedge can be recorded for recording pulmonary arterial pressure. There will be conditions where we want to know the pulmonary artery pressure. For example, a tricuspid atresia patient. If you want to see the suitability for a tricuspid atresia patient for a Glenn or a Fontane surgery, and you want to confirm that the PA pressure is less than 15 millimeters of mercury, you cannot enter the PA in a tricuspid atresia because the catheter has to go from right atrium through the ASD into the left atrium, then you enter the left ventricle through the mitral valve, then you enter the VSD and enter the hypoplastic right ventricle, and through that hypoplastic infundibulum, you enter into the pulmonary artery. So this will be like a very circuitous entry. So quite often what we will be doing is what is called pulmonary vein wedge pressures. And in pulmonary vein wedge pressures, what you do is you take a catheter deeply wedge into the pulmonary vein, you'll be recording the other side of the capillary, which is pulmonary artery pressure. So you are able to appreciate systolic pressure trace of the pulmonary arteries through the wedge. So pulmonary vein wedge is another way of recording the pulmonary artery pressures. So when we record a pulmonary artery wedge is actually recorded to see the left atrial pressure. So this is pulmonary artery wedge. When you try to pull back into the pulmonary artery, you will find that the pulmonary artery wedge will be equal to the PA diastolic pressure, or in other words, PA diastolic and PA wedge will be equal. So this is a PA wedge to PA pullback. So this is a patient who is having mild pulmonary arterial hypertension. You see that the PA systolic is almost 38 millimeters of mercury. PA diastolic is almost 16 millimeters of mercury. And we are pulling the catheter back from the pulmonary artery wedge to pulmonary artery. Here the pulmonary artery wedge is also elevated 16 millimeters of mercury. So this is an example of post-capillary pulmonary hypertension. So what is post-capillary pulmonary hypertension? The PA wedge is elevated and the PA diastolic is equal to the PA wedge. In pre-capillary pulmonary hypertension, what happens? The PA wedge will be less than 15 millimeters of mercury. So the PA wedge will be much lower and the PA diastolic will be much higher than the PA wedge pressure. So there is a gap between the PA diastolic pressure and the PA wedge pressure. Whereas here there is no gap. You see that the PA wedge pressure mean is 16 and the PA diastolic is also 16. So here there is no difference between the PA diastolic to the PA wedge. So this is an example of a mild post-capillary pulmonary arterial hypertension. There are two terms that are often taken here. One is called as the mean transpulmonary gradient and one is called as the diastolic transpulmonary gradient. Here, if you look at this, the PA wedge mean is 16, the PA diastolic is 16. So there is no difference between the PA wedge mean and the PA diastolic. So that means the diastolic pressure gradient is sort of zero. A diastolic pressure gradient, if it is higher and higher and higher, that means it is a pre-capillary pulmonary hypertension. Similarly, the other value that is taken is mean PA pressure minus the mean pulmonary artery wedge pressure. That is called as the TPG or transpulmonary gradient. This transpulmonary gradient is yet another indicator. This we often use in the univentricular circulation. In univentricular circulation, if the diastolic pressure gradient, that means between the PA diastolic to the PA wedge mean is more than 3 millimeters of mercury, that is indicator of pulmonary arterial hypertension. This is in univentricular heart situations. Similarly, if the PA mean pressure is more than the PA wedge mean by more than 6 millimeters of mercury, again it is elevated transpulmonary gradient. So these are two criteria, PA diastolic pulmonary gradient and mean pulmonary gradient. In this particular example, the diastolic pulmonary gradient is 0 because PA diastolic is 16 and the PA wedge is also 16. Now coming to aortic pressures. In aortic pressures, the normal aortic forward wave by the LV ejection is called as a percussion wave. So this is basically caused by the ejection of the blood into the aorta. Immediately within the first few milliseconds, this wave gets reflected from all the bifurcation points. So there is something called as a tidal wave. Tidal wave is called as a reflected wave. So the tidal wave will come and keep on hitting against the percussion wave and it will try to augment the percussion wave. So this is the percussion wave followed by the tidal wave, and then there is a dicrotic notch and the dicrotic wave. Now this is a proper ascending aortic pressure trace. Now let us see what are all the differences. This is an example of an aortic pressure trace. The pressures are good, 120 by 80. So the pressures are good, but there is a sharp dicrotic notch and a sharp dicrotic wave. This patient actually was in severe congestive heart failure. So whenever there is a severe congestive heart failure with markedly elevated systemic vascular resistance, the reflected wave will keep on coming from all the peripheral vessels. And so it will be even beyond the dicrotic notch there will be a tall reflected wave. So this is the dicrotic wave. So dicrotic wave is a feature of extremely high systemic vascular resistance. On the contrary, Bispherians pulse is basically double peaking in systole. Dicrotic pulse is second peak is in diastole, whereas Bispherians pulse is double peak in systole. This is caused if suppose this patient is having a combined ASAR, or if it is having a severe aortic regurgitation, it's basically caused by the Venturi effect. A large ejection of the blood from the left ventricle towards the aorta creates a Venturi effect during the middle of the systole, thereby causing a Bispherians pulse. Of course, this can also be seen in bifid pulses as in hypertrophic obstructive cardiomyopathy. I will show an example a short while later. So this is a Bispherians pulse. This Bispherians pulse, if you look at it, is having a wide pulse pressure. Diastolic is 40, systolic is 110. So this is aortic regurgitation. So this is an aortic regurgitation pressure trace. Coming to the difference between what is ascending aorta and what is a peripheral pulmonary artery. The peripheral arteries like radial artery or femoral artery, the peripheral arteries will have taller systolic wave. This is called as the peripheral systolic amplification. And you look at the dicrotic notch will be at a much lower level in these peripheral arteries compared to ascending aorta. In ascending aorta, the dicrotic notch will be at a much higher level, whereas in the peripheral pulmonary arteries, the dicrotic notch will be at a much lower level. When you take an LV to aorta pullback, this will expose the aortic stenosis. So this is a pressure of 130 in the LV and about 100 in the aorta. So that there's a 30 millimeters of mercury pressure gradient coming to mild to moderate aortic stenosis. So look at the pressure trace in a left ventricle and the pressure trace in the aorta. A difference between LV to aorta more than 50 millimeters of mercury is called as severe aortic stenosis by catheterization. While by echocardiography, a peak gradient of 64 and a mean gradient of 40 is considered as severe AS. In congenital aortic stenosis, a gradient of more than 50 millimeters of mercury is considered as severe aortic stenosis. One of the some of the concepts that is told, this is actually, if you look at this pressure trace, this is the left ventricle and this is the femoral artery trace. So there is a phase delay here. There is a phase delay. The femoral artery comes at a much later level. In general, the rule, if you overlap an LV to an aortic trace, the peak-to-peak gradient is between the peak of LV to the peak of aorta, whereas peak instantaneous gradient is from the peak of LV to the corresponding portion of the aortic trace. So this is what we record by echocardiographic peak gradient is the peak instantaneous gradient, whereas the peak-to-peak gradient is the one that is measured by the catheterization. In hypertrophic cardiomyopathy or in subaortic stenosis, as you pull back the LV from LV to the subvalvular LVOT, there will be a pressure drop, and that pressure will be the same in the ascending aorta. So this is subvalvular aortic stenosis, whereas in supravalvular aortic stenosis, this is the aorta above the supravalvular, or in other words, at the level of aortic root, and this is at the level of beyond the supravalvular. This is at the level of aortic arch. One important thing that we have to see here is the systolic pressure is quite high because of the severe stenosis, but the diastolic pressure is very low. The diastolic pressure is equal to the aortic diastolic pressure. The reason why the diastolic pressure is quite low is because there is an equalization of the diastolic pressure between the aortic root and the arch of the aorta in supravalvular aortic stenosis. This is completely different from the coarctation of aorta. In coarctation of aorta, aortic diastolic pressure is higher in the upper part of the aorta and the aortic diastolic pressure is lower in the lower part of the aorta. The reason why it is so is there is a resetting of the baroreceptors. Whereas in supravalvular aortic stenosis, the high pressure is exposed only to the aortic root. It is not exposed to the aortic baroreceptors in the aortic arch or in the carotid body. So there is no diastolic hypertension. So diastolic pressures are low in supravalvular aortic stenosis. So what you get is only a systolic gradient. So if you look at the Doppler tracing, there will be only systolic gradient. Whereas in coarctation of aorta, there will be a diastolic spill. The Doppler will show even during diastole, there is a persistent gradient. If I overlap a coarctation, aortic diastolic will be lower than ascending aortic diastolic will be higher, descending aortic diastolic will be lower. So there is a diastolic gradient also. This diastolic gradient is caused by resetting of the baroreceptors because the upper part where the baroreceptors are present are exposed to a higher pressure. And this, the moment it is reset, you get a diastolic hypertension. The systemic vascular resistance goes up. So the difference between a supravalvular aortic stenosis, there is no diastolic gradient in a supravalvular aortic stenosis. It's only systolic gradient, whereas in coarctation, there is both a systolic and a diastolic gradient. Now, briefly coming to differences between constrictive pericarditis and restrictive cardiomyopathy. As I told you earlier, this trace I showed you, there is no inspiratory change at all. Inspiration and expiration is constant. A markedly deep Y descent is the peculiar feature of constrictive pericarditis. This is called as the Friedreich sign. Now you look at right ventricular pressure trace. The right ventricular pressure trace has got a sharp dip and a high diastolic. So if you look at the diastolic pressure here, it's almost coming to around 24 to 28 millimeters of mercury. But if you look at the RV pressure is only about 40 millimeters of mercury, 42, 43 millimeters of mercury. So the RV end diastolic pressure is much higher than 1/3 of the RV systolic pressure. And this is called as the dip and square root pattern. So RV end diastolic pressure is disproportionately higher for the level of RV systolic pressure. In the left ventricle, this is the dip and square root pattern. Again, you are finding that the left ventricular end diastolic pressure is close to about 24, 25 millimeters of mercury. So the dip and the square root. If I overlap both together, you will find that the dip and square root pattern is seen in both LV and RV, and the end diastolic pressures are almost similar. If at all they are different only by about 5 millimeters of mercury. There is not too much of difference between LV end diastolic pressure and the RV end diastolic pressure. So the general rule in constrictive pericarditis is RA mean is equal to RV end diastolic pressure. RV end diastolic pressure is equal to PA diastolic pressure. PA diastolic pressure is equal to PA wedge pressure. And the PA wedge pressure is equal to LV end diastolic pressure. Or in other words, all the mean pressures and the end diastolic pressures will sort of be similar. The diastolic pressure, the mean pressure within the atria, the diastolic pressures in the ventricle, and the PA diastolic pressure all will sort of be the same. So here the PA mean is also the PA diastolic pressure is also 24 millimeters of mercury. Here, taking the PA mean is 24 millimeters of mercury. Everything is like sort of 24 millimeters of mercury. One thing that we need to understand about this A and B waves and a PA wedge trace, you see that this is the P and the QRS. The A wave has got a phase delay. So there is a gap, there is a delay at the time when the A wave happens, because the PA wedge is detecting the LA pressure after a time. So this is A wave as well as the V wave will be delayed. Normally the V wave will happen during the QRS to T wave. Here the V wave has fallen. This is called as a phase delay. So this phase delay is a feature of a wedge pressure. And here also if you find sharper Y descents, so these Y descents are called as the Friedreich sign. Why does the Y descent become so sharp? Because it's only the filling of the heart happens only during the early diastole. Apart from early diastole, there is no other time at which the heart can fill, because the heart has got a very limited volume that it can accommodate, and that entire volume it accommodates only during the early diastole. So there is a steep fall of the LV end diastolic pressure and the RV end diastolic pressure, and correspondingly there is a steep fall in the atrial pressure. This is the steep Y wave. So that is the reason why this is called Friedreich's wave, or very sharp Y descent. So in general, the rule in constrictive pericarditis and restrictive constrictive pericarditis is that the end diastolic pressures, both the end diastolic pressures are all sort of similar. If at all they are different only by about a short distance of 5 millimeters of mercury. And the right ventricular systolic pressure is never too high compared to the right ventricular end diastolic pressure. So in other words, right ventricular end diastolic pressure will be at least more than 1/3 of the right ventricular systolic pressure. And you find that there is during inspiration, the left ventricle does not fill nicely, and so there is a left ventricular pressure fall, whereas the right ventricle fills nicely, so the right ventricular pressure increases. The reason why this happens is, whenever there is an inspiratory indrawing of the blood from the systemic veins into the thoracic cavity, the blood reaches the RA, enters the right ventricle. Right ventricle has no space except pushing the intraventricular septum towards the left side, thereby compromising the left ventricular volume. So the left ventricle falls during inspiration, right ventricle increases during inspiration. So the area under the curve becomes smaller during inspiration, whereas during expiration, the left ventricle becomes much taller, the right ventricle becomes much lower. So the area under the curve becomes much wider. In a restrictive cardiomyopathy, this is an aortic pressure trace of a restrictive cardiomyopathy. What we see here, the right atrial pressure is again elevated. It's almost close to 18 millimeters of mercury. Here, the Y descent is not so prominent like constrictive pericarditis. So, prominent Y descent is actually a peculiar diagnostic feature of constrictive pericarditis. Here, the Y descent is not so deep as in constrictive pericarditis. And if you look at the right ventricular pressure, the right ventricular pressure is elevated because the left ventricular pressure elevation causes secondary pulmonary hypertension. So the right ventricular pressure is elevated. Now this is about 75 millimeters of mercury. The end diastolic pressure is 24 millimeters of mercury. So the RV systolic by RV end diastolic pressure, that ratio, this becomes more than 1/3. So in other words, the RV systolic pressure is much higher in a restrictive cardiomyopathy compared to constrictive pericarditis, where the RV systolic pressure will be much lower. And this is the right ventricle in the restrictive. So the end diastolic pressure goes up to 24, but the systolic pressure is quite high at around 70-75 millimeters of mercury. So this is the left ventricle in the same pressure. Here, the left ventricular pressure, while the right ventricular end diastolic pressure was 24, the left ventricular end diastolic pressure is almost 40 millimeters of mercury. So there is a difference between the RV end diastolic and the LV end diastolic. LV end diastolic pressures will be much higher than the RV end diastolic pressure. This is the LV end diastolic pressure, almost touching 40 millimeters of mercury. And this is the pulmonary artery pressure in RCM. As I told you earlier, pulmonary hypertension will happen. So this is pulmonary artery pressure of 65/40. So pulmonary artery, there is a mild to moderate levels of pulmonary arterial hypertension. Again, if you look at the PA diastolic pressure, the PA diastolic pressure is much higher than the LV end diastolic pressure and the left atrial pressure. So that means this patients, unlike the constrictive pericarditis where the PA diastolic will be equal to the PA wedge, here the PA pressure goes up. So there is some element of precapillary pulmonary hypertension which will happen also. So this is the PA wedge pressure in RCM. So the PA wedge here is quite elevated to almost 40 millimeters of mercury. Right ventricular end diastolic pressure is not so high in RCM. This is only 24 compared to the left ventricle, which was 40. So the difference here is that the right ventricular, the pathology will be much less. Here, the variation between inspiration and expiration between the traces will not be so drastic. The exaggerated ventricular interdependence is a feature of constrictive pericarditis. Last trace will be hypertrophic obstructive cardiomyopathy. Typical hypertrophic obstructive cardiomyopathy will have a combination of LVOT obstruction plus systolic regurgitation. If you look at the standard LV pressure trace, there will be a late peaking. I earlier mentioned that left ventricular isovolumic contraction is steep, that always the LV will be rectangular. Whereas in hypertrophic cardiomyopathy, LV keeps on going to its peak. So it's a late peaking LV. So this late peaking is contrary to aortic pressure, which is spike and dome pattern. This is early peaking. So while in aortic stenosis, in a typical valvular aortic stenosis, this ascending aorta will be anacrotic, will be very slow rise. In hypertrophic cardiomyopathy, it will be a sharp upstroke. So this is a spike and dome pattern. This sharp upstroke followed by dome is called as the spike and dome pattern. And this late peaking of LV is a characteristic of hypertrophic obstructive cardiomyopathy. You can also appreciate left ventricular end diastolic pressure is elevated to almost 30 millimeters of mercury. Let us analyze the pressure much more carefully. If you look at the pressure trace between the LV to the aorta, the gradient will keep varying from time to time. That is the reason why it is called dynamic LVOT obstruction. You see that here, this is much wider. This pressure gap is almost about 60 millimeters of mercury, whereas here the pressure trace is about 45 millimeters of mercury. The dynamic LVOT obstruction is whenever the gradient varies from time to time, because every beat will differ depending on what is the systemic vascular resistance and what is the myocardial contractility. But the general rule is late peaking of LV and the spike and dome pattern of the ascending aorta. The more and more the obstruction, the more will be the spike and dome. Here you see that the spike is very tall and the dome is short. Whereas less of obstruction, the spike will be less and the dome will be equal. So you see the dynamicity of the obstruction. The more the obstruction becomes, the spike becomes too tall and the dome becomes too short, too much less. So what is a Broken-Brough-Braunwald effect? Broken-Brough-Braunwald effect is whenever there is an ectopic, the next beat will produce an augmented left ventricular contractility. So this long diastolic pause will give an augmented left ventricular contractility, and this will increase the left ventricular outflow tract obstruction also. So proportionately, the aortic pulse pressure will go very low. So you will find a reduction in the aortic pulse pressure, but an augmentation in the left ventricle. So in a post-ectopic beat, the aortic pulse pressure will be very, very small. And this is called as the Broken-Brough-Braunwald effect. So it is important to understand what is actually a post-ectopic beat. An ectopic in a normal left ventricle leads to a longer pause. This prolongs the diastole. And this prolonged diastole will lead to a lot of filling of the left ventricle. So the left ventricle will eject with a larger stroke volume. But this longer diastole will also lead to a fall in the systemic vascular resistance, thereby leading to a fall in the diastolic pressure. So a post-ectopic beat that leads to an increased stroke volume. The stroke volume still does not raise the aortic systolic pressure because aortic diastolic pressure in the previous beat has fallen to low levels due to low SVR. Since the aortic systolic pressure does not rise, there is no rise in the LV pressure also. So a typical normal left ventricle, there is no post-ectopic elevation of LV pressure, but aortic pulse pressure will increase because the previous wave's diastolic pressure will be low. I will show an example. Post-ectopic beat in LV has the same pressure, same systolic pressure. Aorta also has same systolic pressure, but a wider pulse pressure. But in HOCM, a post-ectopic powerful contraction leads to increase in the left ventricular outflow tract obstruction. This leads to elevation of the LV systolic pressure. And since the worsening of the LVOT leads to fall in the aortic pressure, this widens the gap and the gradient becomes marked. I'll show an example. This is a post-ectopic beats. See, whenever there is a post-ectopic beat, the gradient becomes too high. And when the gradient becomes too high, when the LV becomes so much hypercontractile, the aortic pulse pressure becomes so low that the patient will actually go into a syncope. So this is what is called as a hemodynamic syncope. 1 or 2 ectopics can lead to very powerful left ventricular contractions, and they can completely obliterate the aortic pulse pressure. And in these patients, the very low diastolic, very low aortic pressures will lead to almost sort of a syncope, a drop in the blood pressure, and these patients will experience a syncope. These are quite a lot of ectopics, and too many ectopics are producing so much of dynamic LVOT obstruction. Whereas when these ectopics sort of settle down, when the series of ectopics just settle down, what happens? Immediately, all this time, the patient was having very low pressures. So the compensatory increase in the systemic vascular resistance, the increase in the systemic vascular resistance now sort of nullifies the LVOT gradient. So what was here a dynamic severe LVOT obstruction is almost becoming sort of totally zero gradient. This is what is called as dynamic LVOT obstruction. So this is not a fixed obstruction. The ectopics trigger increase in the LV contractility, fall in the aortic pulse pressure, marked increase in the gradients, cause syncope. That syncope leads to marked increase, the shock-like state leads to increase in the SVR. The increase in the SVR, once the rhythm becomes normal, immediately takes away the gradient, and there is no gradient at all. So this is what is the peculiarity of dynamic LVOT obstruction. The same thing will happen when the patient is not having any obstruction at all. You give amyl nitrate, make the SVR fall down. You can make the spike and dome pattern become very classical. So this is the sharp spike with the slow dome. So the LVOT gradient is worsened. So you can, the dynamicity of the LVOT gradient is shown by these 2 traces, where here you see that following a syncope, the patient just recovers with 0 gradient. And here, the patient who is having a 0 gradient, the moment you provoke him with the amyl nitrate, it goes into this much of obstruction. So this is the reason why this is called dynamic LVOT obstruction. And what is the reason for breathlessness in a patient with hypertrophic cardiomyopathy? You see here, this is a elevated LV end diastolic. This is a elevated LA pressure. The reason why the LA pressure is elevated is because the left ventricle is not very compliant, and so you are having a elevated LA pressure. But when the LVOT obstruction increases, what happens? This is a worsening LVOT obstruction. You are finding that here there is a spike and dome. Here the spike and dome is even more common. That means we are basically progressively worsening the LVOT obstruction. And here proportionately the LA pressure is keeping on increasing. The LA V waves are becoming taller and taller. So this is just as how LVOT obstruction worsens dynamically, LA pressure will also worsen dynamically. So this is LA pressure increasing progressively over this curve by an increasing in the LVOT obstruction. The moment you obliterate the LVOT obstruction by an alcohol septal ablation, immediately you result in the gradients totally going off and the left ventricular end diastolic pressure normalizing. Here you find that the left ventricular end diastolic pressure has started touching 12 millimeters of mercury. So basically, relief of LVOT gradient created by an alcohol septal ablation, there is a dramatic difference in the LVOT gradients. The same way, the trace which was showing tall A and B waves, now the LA pressure is quite come low. It has come to around 8 to 9 millimeters of mercury. Now, before just winding up the last few slides, we should be aware about all the artifacts. The artifacts can be anything, physiological, related to damping. I'll just show examples. Artifacts of tachycardia. Whenever you have a heart rate that is very, very, very slow, you will find all the waves such as A wave, X descent, V wave, Y descent. Whereas when there is a very rapid heart rate, because the frequency of our usual transducers are not tuned for any heart rate that is more than 120, the traces will go bizarre. So your aortic pressure as well as the CVP pressure, everything will go very bizarre and you will not be able to appreciate. So tachycardia is an important artifact. Underdamping. I showed the first slide itself an example of an underdamping. So these are a pulmonary artery pressure curve. You can see that as the PA diastolic goes down, sharp flings down. So these are all underdamped tracings. These underdamped, ideally the pressure has to be something like 45 systolic with 25 diastolic. But these sharp waves are due to underdamping. So the underdamping are recognized by tall peaks and deep troughs. So it's important to recognize it. The third one is deterioration of frequency response. This is a pulmonary artery pressure curve. If you look at the pulmonary artery pressure curve, the waveforms are totally lost and it is having multiple steps. This is basically a frequency response getting worsened and worsened. If you can fill the fluid, aspirate the entire fluid and replace with saline, sometimes it may get better. If it is not getting better, you have to change the transducer. Catheter whip artifact. Whenever you are using a balloon flotation catheter, the movement of the balloon up and down, forward and backward will produce an up and down movement of the pressure curve. So ideal pressure has to be something like this. But whenever you are using with a balloon flotation catheter, you will have marked fling up and down. So whenever you are floating a PA balloon catheter, you deflate the balloon and then record rather than with the full balloon. With the full balloon, the forward movement and backward movement, it's called as the catheter whip artifact, will produce a lot of fluctuations. End pressure artifact. Whenever there is an aortic stenosis, if you directly take at the top, this pressure will be 10 millimeters of mercury higher. In a pulmonary stenosis, when you are taking away from it, the pressure will be 10 millimeters of mercury lower. So we need to be understanding what is called as the end hole upstream artifact and the end hole downstream artifact. Catheter impact artifact. If the catheter is going to be touching an adjacent structure like a valve, papillary muscle, atrial wall, moderator band, there can be too much of flings corresponding to the impact. So these sort of pressure artifacts have to be understood, and we have to adjust the catheter so that it doesn't touch the adjacent walls. Peripheral systolic amplification, we all know about it. It is due to the reflected waves coming. The more and more you are peripheral, your systolic pressures are going to be higher. Zero level error, you would have started the pressure tracing with the patient lying down. But as the patient develops pulmonary edema and you are lifting the patient up with a pillow, you are not changing the zero, the transducer level. So this will give what is called zero level artifact. Balancing artifact. The two pressure transducers that you are taking are not, one is not balanced. So one sort of drifts. This is called as the zero drift. So the zero drift is actually a balancing error. And so here you again, you recalibrate the patient, then this is called as a balance. Calibration error is the same pressure curve. If you put it in two transducers, it will result in two different. So this is basically an abnormality in the calibration. Again, you have to recalibrate the machine. Entrapment artifact, when you are taking a left ventricular catheter like a pressure trace, if you are putting an end hole catheter like a right coronary artery catheter or a multi-purpose catheter and put it into the left ventricle, it may get trapped within the trabeculae and you will have a falsely higher pressure, giving an impression of aortic stenosis, whereas this is not actually an aortic stenosis. This is a end hole catheter entrapped within the left ventricular myocardium. Progressive flattening to sine wave due to thrombus formation and physiological variation due to respiratory variation. This is a marked respiratory variation, or even when you have an underfilled heat status, you will have this lot of respiratory variation. So we have to understand the pressure trace. This is the last concluding slide. It's the best way to understand cardiac hemodynamics. The pathophysiology of each and every disease is clearly shown on the pressure traces, and you should pay a very careful attention to these pressure traces. And significance of each lesion is highly dependent on proper interpretation of the pressure traces. Thank you very much.
Thank you, sir. I would first invite Snehal ma'am's comments.
Yeah, thank you, Shiva, very much. It's great understanding and learning, but not for students, but I think for all the practicing cardiologists as well. One of the things I want to just elaborate or ask, for measuring intracavitary pressures or especially pulmonary artery or pulmonary wedge pressure, we need an end-hole catheter. And now it's really getting difficult to get a Swan catheter. So what catheters you usually use for your
I was going to ask the same question.
Yeah, the currently the previously what was available from the Arrow is now not available. On the contrary, there is an Edwards catheter, which is a Savant French balloon flotation catheter, which is available. It's available from the Edwards company. But unfortunately, it's Savant French. It's not. It's no longer the 5 and 6 French that were available with the previous Arrow. It was also available with the B Braun, but now they all have not distributing in India. So the only balloon flotation wedge catheter that is currently available is a Savant French Edwards triple lumen catheter. It has got 3 lumen. It has got proximal 15 centimeter lumen also, which we have to blind it out.
It's like a thermodilution, you mean?
It's not truly a thermodilution catheter. That will be a 4th port. This is basically they keep it. This is primarily meant for measuring the pulmonary artery pressures in a patient post CABG in the ICU. It's meant to be passed through the jugular sheath, and without thermodilution, it is available. It's Savant French Edwards.
So for day-to-day practical use, because most labs are not going to be having this catheter, which would you say is an ideal catheter for measuring the PA pressures and the PA wedge pressure?
We normally take a pulmonary artery catheter with a standard end-hole catheter, and if we can go in and wedge the same end-hole catheter like a multipurpose or a right coronary artery as deep as possible, and if you are getting a very reproducible trace in 2 or 3 places, then we accept it as the PA wedge pressure.
And you talked about, sir, the peak instantaneous and peak-to-peak gradients, the echo and CAT discrepancy that we typically get in aortic stenosis. Would the students would, I think, also like to be told about a similar discrepancy on the right side when we are measuring the pulmonary artery pressure. So could you please elaborate on that?
Yeah, in aortic stenosis, these numbers are far more crucial and far more prognostic, because the definition of aortic stenosis is more than 64 millimeters of mercury peak instantaneous gradient, or in other words, a co-peak to peak gradient, and a mean gradient of 40. In pulmonary artery pressure, it's far more forgiving, and hence very often a severe pulmonary stenosis is defined as more than 50 millimeters of mercury, or RV systolic pressure more than 2/3 of the systemic pressures. So assuming that I have an aortic pressure of 120, a pressure of more than 80 millimeters now becomes severe pulmonary stenosis. So right heart is far more forgiving, and hence in right heart the gradients are variably described. More than 50 is severe, more than 2/3 systemic is also severe.
Right.
In
We have a
left heart, it is very, very, very important.
Right. Sir, one question from the audience. I'll just read out the question. Why are respiratory changes reflected in the ventricle but not in the atrium in a patient with CP? Considering there is a uniform envelope, we saw no changes in the atrial pressure tracings.
Yeah, respiratory changes in the ventricle is caused by a different mechanism. As I mentioned, whenever we are inspiring, the negative intrathoracic pressure sucks in the blood into the right atrium. This whole of this right atrial blood enters the right ventricle. Now the right ventricle has to accommodate this additional volume. It cannot expand outside because there is a rigid pericardial shell. So it has to move the ventricular septum towards the left ventricle. So the right ventricle accommodates a larger volume at the cost of left ventricle. So this is what causes the septal bounce. When you are doing an echocardiography in a patient who is having constrictive pericarditis from an apical four-chamber view, as the patient inspires, the septum bounces towards the left ventricle, and as the patient expires, the septum bounces towards the right ventricle. So when you are having a higher right ventricular filling, the higher right ventricular filling will lead to higher RV stroke volume. This higher RV stroke volume will result in a higher RV systolic pressure. So RV systolic pressure will elevate in constrictive pericarditis at the cost of LV.
Right.
Last question, Shiva. There's some. Can you enlighten us on pressure recovery in pediatric patients with aortic stenosis?
Yes. So let's see what is happening to the LV pressure as the blood. Let's assume that there is a patient with 50 millimeters of mercury pressure gradient between the LV and aorta. So left ventricular pressure is 170 millimeters of mercury and the aortic pressure is 120 millimeters of mercury. So there's a 50 millimeters of mercury pressure fall at the level of the aortic valve. For this same 50 millimeters of mercury pressure fall, let us have two different patients. Take first patient who is having a bicuspid aortic valve with a markedly dilated aortic root and a markedly dilated ascending aorta. Take a second patient who is having a senile calcific aortic stenosis with a small aortic root. Let us say a senile calcific aortic stenosis in an elderly lady who is having a small aortic root and a small ascending aorta. As soon as the blood enters from the left ventricle into the aorta, the pressure falls from 170 to 120. So there is a 50 millimeters of mercury gradient. And as the blood continues to go towards the sinotubular junction and the ascending aorta in the smaller aorta of a senile calcific aortic stenosis, the pressure increases. This increase in the pressure is called as the pressure recovery. So ultimately what will happen is, if you have a pressure catheter that is one catheter in the left ventricle and one catheter in the femoral artery or one catheter in the aortic arch, the pressure would have recovered in the senile calcific aortic stenosis by the time it reaches the arch. So what will now happen? The pressure was 170 in the left ventricle, it drops down to 120 at the level of the aortic valve and increases to 140 at the level of aortic arch, thereby giving a gradient of only 30 millimeters of mercury. So this recovery is called as the pressure recovery, and this is caused by a smaller aorta. On the contrary, if it is a bicuspid aortic valve with a hugely dilated ascending aorta and a hugely dilated aortic root, this pressure will not recover. So the pressure will continue to be 100, 120 distally also. So pressure recovery is a feature that is seen, which is basically an increase in the pressure as you move away from the stenotic junction. If the aorta is smaller, whereas if the aorta is dilated, it does not recover. It continues to be the same. So the corollary for this is, if you are having a patient with a markedly dilated aortic valve, markedly dilated aortic root, and if you are getting a 50 millimeters of mercury pressure gradient, if you take them into the cath lab, you will still have a 50 millimeter pressure gradient. Whereas in a patient with a senile calcific aortic stenosis, you go and do an echocardiography, you have a pressure gradient of 50 millimeters of mercury, you take the patient into the cath lab and do a LV to aortic arch pressure gradient, the pressure gradient will be lower. So you will get a lower value in the cath lab in a patient who is having a senile calcific aortic stenosis with a narrow ascending aorta because of the principle of pressure recovery. So they will not demonstrate the same level of LV to aorta pressure gradient as a bicuspid aortic valve with a markedly dilated aortic root and ascending aorta. I think the Dheeraj Kumar's question is also the same pressure recovery.
And the same question I'll ask. Same question.
Yeah. There was another one more question that okay. The same thing. Yeah.
So it is better to record in senile calcific aortic stenosis, keep the catheter as close to the aortic valve as possible.
Not necessarily. Ultimately, the pressure difference is what is the principle of pressure recovery is it recovers back. So the actual clinical gradient is going to be something that what echo will overestimate. That's all. Echo will give a higher value of a gradient, whereas in truth, when you go and put in catheters, it will not be so bad.
Okay, thank you, Shiva. Thank you for
Wonderful.
and really our students and I, as I said, every practicing cardiologist will appreciate and must have learned a lot from this talk. And hope I think the one which was scheduled is still remaining, so that we have to have such time later.
Yeah, thanks Shiva for an excellent deliberation. I think it will be extremely difficult to find what you have said in any book or anywhere, I suppose so. Good. So I would now request our Professor Dr. Dheeraj Kumar from KEM Hospital to give a formal vote of thanks. And before that, I will just say that this is just the first one, and I would request the PGs to attend. Every month we'll have at least one talk like this, so that all of us learn and you get all the information. Dheeraj, please go ahead. Yeah.
Sir, it was indeed a comprehensive and comprehensive okay. Thank you, sir, for the comprehensive review of a complex topic like hemodynamics, and it must have definitely benefited all our PG students, and also it must have served as a refresher course for us who are already in practice, who are using hemodynamics on a day-to-day basis. On the behalf of CSI Mumbai chapter, I would like to extend gratitude towards you for having spared so much time and effort for taking this wonderful lecture. This is just the beginning. We have many more lectures to come. Hopefully, we can call you again for some other topic during this lecture series of PG track program. Our basic endeavor is to cover foundational concepts which are very important for PG students in order to have a deeper understanding of cardiology. Thank you, sir.
Yeah, maybe a few months later, I can talk on specific in congenital heart disease. I came to know about congenital heart disease only like when I saw the note today. So maybe a few months later, I'll specifically talk only on congenital heart disease. Maybe take lesion by lesion. What is the relevance in ASD, relevance in VSD, relevance in PDA, like that. Go on up to univentricular heart, tetralogy, TGA, everything, and discuss maybe that on another day.
Actually, it was good that you started with the basics. So now that will be a good base for you to build on in your next lecture. The students would understand better. And I would just add to Dheeraj's vote of thanks that we are grateful to Sun Pharma for all their generous sponsorship, and we are grateful to Dr. Kane sir for envisaging this PG track program and the executive committee of CSI. And we wish everybody a good night. And Dr. Shiva sir, please keep joining us in our programs. Thank you so much. Thank you.
Thanks, everybody. Yeah, bye.
Thank you, sir. Thank you.
Bye.